Okay. Good morning, good morning, good morning. Good morning, good morning. Hello. 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 Welcome to a brand new month. Today is the 1st of July. I would like to welcome you to Iwosan Lagun Hospital's Doctors Forum. Good morning to our dear participants, esteemed colleagues, and healthcare trailblazers. I'm also saying good morning, good afternoon, good evening to all those who are watching us on live stream, on YouTube, and all our social media handles. You're very welcome to Iwosan Lagun Hospital's Doctors Forum, where knowledge meets impact and practice meets purpose. It's such a pleasure to see this room full of brilliance and seasoned clinicians who move forward to future-forward specialists. You're in for a truly enriching experience today. My name is Olurotimi, family physician with Iwosan Lagun Hospitals, where we are a consistently patient-first, world-class healthcare services provider. We are empathetic, we are ethical, we are knowledge-driven, innovative, and we are accessible. And our promise always is that we will look after you. And I promise to look after you today. Thank you very much. I'm very excited to be here. I'm very proud of Iwosan Lagun Hospitals, and I'm especially proud of all the people who are at the helm of our affairs. And I'd like to use this to just acknowledge some very special people in the house, very handsome, beautiful people in the house who make my working there a pleasure every day. So I'd like to welcome my Oga, Dr. Oyeniro, the MD, CEO. That's a big name, please. Clap. That clap is not resounding. Is it easy to be an MD CEO? I will be there one day. Oh. I'm walking in his footsteps. I've got to study his profile. All the steps he took. I've started following it so that me too one day I will be there. So I'd like to welcome this special gentleman into our midst. Thank you, sir, for being here and supporting us today. It is your program, just like it's our program. I'd like to acknowledge a very beautiful lady. I've known her since she was like this, when we were like this. Yes. I'd like to welcome her. She's Dr. Tomi Kogo, the MD Iwosan Lagun Hospitals Outpatient Clinics Idejo. You are very welcome, ma. Thank you very much. We have very, very esteemed people in this place. I will get to welcoming them, but I'd just like to say a round of applause to all the people in the room today for making out the time to be with us, to share, to learn, and to grow. Our theme today reflects the beating pulse of modern medicine, from preventable cardiovascular diseases, challenges, to the complexities of brain tumors, all framed by the expertise of global icons and homegrown champions. But first, let's meet the woman powering this excellence engine, this Doctors Forum. I'd like to introduce a woman very dear to my heart. I work with her on a daily basis, and the warmth that flows from her to me, as I said, you're very welcome. A round of applause.
Thank you, Dr. Husseini. Good morning, ladies and gentlemen. Thank you for coming. On behalf of the board, the executive management, and staff of Iwosan Lagun Hospitals, I'd like to warmly welcome you to this Doctors Forum. I believe it's going to be a very enriching and impactful session this morning. before we go ahead, I'd just like to just talk to us briefly about Iwosan Lagoon hospitals. Can I have this quickly? Thank you. Towards them. Okay. So I know we went through this earlier. Dr. Oseni, thank you. We have our vision and our values. We've done that, but we'll take that again quickly, if you just pardon me. So please join us as we take our vision and our values. We are a consistently patient-first, world-class healthcare services provider. We are empathetic, ethical, knowledge-driven, innovative, and accessible. And our brand promise is that we will look after you. Thank you very much. Yes, so just a brief history of Lagoon Hospitals. Lagoon Hospitals was established in 1984 by the late Professor Emmanuel Elebute and Professor Mrs. Onyade Elebute, and began operations in 1986. Fast forward to 2011, Lagoon Hospital became the first hospital in sub-Saharan Africa to earn the gold seal of approval of the Joint Commission International. And we've had a reaccreditation done in 2014, 2017, 2021, and 2024. And then fast forward again to 2021, Lagoon Hospitals was acquired by an indigenous private healthcare investment company, Iwosan Investment Limited, dedicated to investing in the Nigerian healthcare market. And we are backed by a team of highly competent professionals with robust experience across diverse sectors. And really combined amongst them, we have our board members. We have over 100 years of combined experience. Chairman and co-founder is Mr. Fola Adeola OFR, and co-founder and CEO, Mrs. Fola Shadelawe. Also on our board, sitting on our board is Professor Yeshiku, is a professor of neurosurgery and a professor of medicine and endocrinology at the University of North Carolina, Chapel Hill, USA. And we also have a management team for Iwosan Investments Limited. Now, for Lagoon Hospitals, is currently the largest private healthcare services group in Nigeria with 5 healthcare facilities. And right now, we are the only JCI accredited hospital in Nigeria. I will speak to our quality journey shortly. Thank you. So, sitting at the helm of affairs for Lagoon Hospitals, we have our CEO, Dr. Olubisi Oyiniro, is also the managing director of Ikoyi Hospital, which is a center of excellence for critical care and advanced surgical operations. We met him earlier. We have, myself, Dr. Ayobami Kuyoro for Iwosan Lagoon Hospital, Legally Victoria Island. We have Dr. Oluyemisi Odubayo, is the managing director of Iwosan Lagoon Hospital, Ikeja. And we have Dr. Olurotimi Kogo, managing director of Iwosan Outpatient Clinic, Idejo, Victoria Island, Lagos. So we're a network of 3 hospitals and 2 outpatient clinics, and each of our hospitals a center of excellence. I'll speak to that subsequently. We have 120 functional beds across our hospitals, and really we have over 300,000 registered patients. We see over 12,000 patients monthly, and we have over 500 inpatient admissions monthly. And really we're known for providing high quality and patient-centric primary, secondary, and tertiary medical care. Now, to our centers of excellence, Iwosan Lagoon Hospital Ikoyi is our center of excellence for critical care and advanced surgical operations, and we're able to do really the most complex surgical operations across all surgical specialties: neurosurgery, general surgery, colorectal surgery, orthopedic surgery, ENT, cochlear implants, the whole works. We are able to do that at Lagoon Hospital Ikoyi. Well, let me say that each of our hospitals is a multi-specialty hospital. However, we have, they are centers of excellence, so they're able to do really any other thing there. And then our hospital in Ikeja is the center of excellence for mother and child. And there we're really able to do, complex gynae surgeries, take high-risk pregnancy, we have a neonatal ICU, and we take babies as small as 25 weeks. So we're able to do all that there and really take care of from conception to birth to adulthood. And then we have our Center of Excellence for Cardiology and Cardiac Surgery in Victoria Island. And in here we have a catheterization lab, and we're able to do, the most complex cardiac procedures, interventional cardiology, endovascular interventions, including neuroendovascular interventions, and also interventional radiology, and the whole works of cardiac care, really from prevention all the way to cardiac rehabilitation. And we have our outpatient clinics. We have one in Victoria Island, Badero, and we have another one in Ikeja on the mainland, and Adeni Jones, where we have our ambulatory care services. Now, just to round up with our quality journey, I think it is very important. We're all doctors in the room. Now, Joint Commission International is the world's leader in healthcare accreditation and the author and evaluator of the most rigorous international standards in quality and patient safety. Like I mentioned, Lagoon Hospitals is the first service provider in West Africa to be JCI accredited. I think we deserve another round of applause. Yes. And so yes, we had our first accreditation in 2011, and we've been reaccredited 4 times. And really all staff members from the top management are involved in ensuring that quality service is being rendered. And to maintain this achievement, we continuously create environments that focus on quality, patient safety, standard operating procedures, and continuous improvement. So really, if you send your patients to us, be assured that we will look after them. So I will stop right there so that we can get into the main meat of today. So thank you, everyone, and you're welcome once again. We help each other, yes.
A warm round of applause for Dr. Ayobami Kuyoro. She just took you through our story, very shortened version of our story. I can assure you that it's very long and very insightful on our growth through the years. Thank you very much for that. We appreciate you. So I'd like to just start by moving on to our housekeeping rules. It's very important. We have very esteemed speakers in the house, and we would not like to distract them as they share from their wealth of experience. So we would appreciate it if we modulate our conversations during the period where they're talking so that we can gain as much as possible from them. Sorry. Yes, so that we can gain as much as possible from the conversations. Would like us to put our phones on silent or possibly on vibrate so that we do not distract one another during the presentation. We would also like to appreciate everyone to try not to do recordings or take pictures so that we do not distract ourselves and distract our speakers during the conversations. We're going to have a question and answer session at the end of each speaker's presentation, and then we would appreciate it if you would just raise your hand and a microphone will be given to you to speak, and you just give us a brief introduction of yourself before you go ahead with your question. In case of an emergency, we have emergency exits just outside the door. There's one once you leave this door to your left, and there's another one to your far right, and there's a stairwell there that takes you down to the basement where security officers are there to direct you to the Munster point. So please follow those directions just in case we have an emergency. We're going to have a refreshment and networking opportunity. We're having refreshment and networking opportunities, and we should take advantage of those times to maximize the breaks and network and make meaningful connections. In engaging in discussions, please let's be mindful and show mutual respect to one another. Diverse opinions are welcome and encouraged. Feedback is very welcome, so your suggestions matter. Please be sure to drop your questions with the people who will be going around with the question papers. We have some papers on our desk. We can write our questions there if you would not like to stand up and actually ask your question. But most importantly, we expect you to have a great time, learn, connect, and enjoy during this period. And so we move to the meat of our program today. Without further ado, I would like to introduce our very first keynote speaker. This in the person of Professor Olurotimi Badero. Please, can I just have a round of applause for that name, please? Thank you very much. Allow me the honor of introducing a man whose career is a testament to extraordinary brilliance, the world's only interventional cardio-nephrologist, Professor Olurotimi Badero, who combines the healing powers of the heart and kidney and has done so with global acclaim from Yale to Lagos. Now, fun fact, you need to know this. He skipped 2 grades. He skipped 2 grades and still graduated with 9 distinctions in WAEC. Now, that's what we call accelerated excellence. So permit me to read this very full profile. Yes? You would like to know more about this gentleman. Thank you. So he graduated from Yale University with a distinction. Let's start. Oh, yes, thank you. I almost missed this somehow. I've been thinking of how I was going to read all of that, but I will start somewhere. So, Professor Olurotimi Badero, MD, MBCHB, FACP, FASN, FNKF, FASDIN, FMCP, FICA, FASA, FASNC, FACC, FSCAI. A round of applause, please. Thank you very much. Professor Olurotimi Badero is a fully trained, board-certified interventional cardio-nephrologist, combined heart and kidney specialist, who has been recognized as the world's first and only board-certified specialist in this field. He has received several awards for his accomplishments in this emerging field and has been recognized globally for his contributions as one of the leaders in the cardiorenal field. He skipped 4th and 6th grade in primary school and won the best overall student in Nigeria in SS2, graduating with 9 distinctions in his WAEC exams the very following year. He graduated from Obafemi Awolowo University, Ile-Ife, before relocating to the US. In the US, he completed 3 years internal medicine residency training at Sunny Downstate, New York, 2-year nephrology fellowship at the Emory University School of Medicine, Atlanta, 3-year cardiology fellowship at Sunny Downstate, New York, 1-year interventional cardiology and peripheral vascular intervention fellowship at Yale University School of Medicine. He graduated from Yale University with a distinction. Additionally, he completed a 1-year interventional nephrology and dialysis access intervention fellowship at Sunny Downstate, New York, making a total unprecedented 10 years of continuous postgraduate medical training with 6 specialty board certifications. Shouldn't we give another round of applause for that, please? He has received many awards, including a congressional award by the US government, as well as the Nigerian president for outstanding career service, and has been inducted into several academic societies, including Fellow of the American College of Physicians, Fellow Medical College of Physicians, Nigeria, Fellow of the American Society of Nephrology, Fellow of the National Kidney Foundation, Fellow of the International College of Angiology, Fellow of the American Society of Diagnostic and Interventional Nephrology, Fellow of the American Society of Nuclear Cardiology, Fellow of the American Society of Angiology, Fellow of the American College of Cardiology, Fellow of the Society for Cardiovascular Angiography and Interventions. He's a consultant to several African countries and is currently the Chief of Interventional Cardiology Program and Director of Cardiac Catheterization Lab at Iwosan Lagon Hospital, the CEO of Cardiac, Renal and Vascular Associates Jackson, USA, and a visiting professor of medicine at the University of Lagos. Please can we welcome with a resounding round of applause for Professor Olurotimi Badero. You're welcome, sir. So this is the pointer, this is the red light, and then this to move down or forward.
And this is up to.
No, this one is down.
What about forward?
Forward. No, sorry, forward, backward.
Okay, all right, I figured it out. All right, well, thank you, everybody. Good morning. Thank you for the nice introduction. Sometimes when I hear this introduction, I always look around and see who they're talking about, but, you know. All right, so all protocols observed. I want to thank the organizers. I want to appreciate the CEO and all the MDs in the room, and also my co-presenter, Dr. Tayo Ujo, and all the wonderful ladies and gentlemen that are here today. So it's been a pleasure to be here, and hopefully, after this talk, I hope it will begin to change your practice patterns, you know, here in Nigeria, because what we're going to talk about is a global problem. It's not just a problem in Nigeria, it's actually a problem worldwide, and I hope that after this conversation, we are going to begin to change how we practice. So I'm going to start with a little video.
More than 85% of those patients that were on deck for amputation that we were able to save, a doctor never even tried to open up their arteries, and that includes, maybe they treated to the knee, but they didn't even treat below the knee, and these were for diabetics. What's even more interesting is more than 35% of all of these patients were not even told they had PAD. They were told they were getting their leg chopped off because of diabetes, and it gets better because 100% of those, when we suggested they go back and get a vascular evaluation, 100% of them were told they had PAD.
So this is, you know, very interesting because this is my friend Kim Nicholas. She's an Emmy Award reporter in the United States. So as you can see, the topic is peripheral vascular disease and amputation in Nigeria, preventable outcome. So peripheral vascular disease, it's a big problem, and a lot of times it leads to amputation. And I think that, you know, when we focus more on taking care of these patients, we can actually prevent and reduce the number of amputation rates in Nigeria. So these are my disclosures. None of them are important for this talk. I'm going to go very quickly through 3 cases, and these cases highlight the kind of patients you're going to see in your practice. And at the end of this conversation, you will know exactly what to do. So the first patient is a 65-year-old male, comes to your clinic, doesn't have any medical history, blood pressure is suboptimal, okay, and he has diminished distal pulses, labs are here. What would you do if you see this kind of patient in your office? 65-year-old, no medical history, has diminished pulses. The next patient, 50-year-old, is a chronic smoker, okay, has the same symptoms. So the previous patient, 65 years, this is a 50-year-old patient, just with diminished pulses, history of smoking, what would you do? The next patient, 45-year-old patient, has type 2 diabetes and hypertension. These are the medications, blood pressure suboptimal. What would you do for this patient? We'll talk about that as we go along. So we're going to talk about peripheral disease. My talk is going to center along. We're going to talk about the anatomy, the etiology, epidemiology, diagnostic evaluation. I'm going to focus heavily on the medical therapy and risk factor modification, highlighting endovascular techniques as well as surgery. When you compare both of them, I'm going to touch on critical limb ischemia, which is very significant. I'm not going to talk about acute limb ischemia because that's a topic for another day. So let's start with what is peripheral vascular disease? So any vascular disease that's outside of the cardiac structure, okay? So your renal arteries, your carotids, your superior mesenteric, your subclavian. But for the purpose of this talk, I'm going to focus just on a low extremity arterial disease. Now, let me take you through the anatomy. We're all very astute cardiologists and medical doctors and anatomists here, so I know you guys remember this, but I'm just going to, pardon me, to go through very quickly. So your distal abdominal aorta bifurcates into your common iliac arteries, okay? Your common iliac arteries will give up the internal iliac artery and the external iliac artery. The internal iliac arteries gives us a lot of branches. We have the superior gluteal, the inferior gluteal, the obturator, and those ones will feed the pelvic structures, the gluteal structures, and sometimes in the thigh. The external iliac artery comes down, and once it gets into the inguinal, below the inguinal ligament, it becomes the common femoral artery. The common femoral artery will give up the deep femoral artery, or the profunda femoris, which gives up the lateral circumflex, the medial circumflex, and then also gives up perforating branches to the adductor magnus muscle. But the main one is the superficial femoral artery, which goes through the adductor canal, right? It goes into the femoral triangle, it goes to the adductor canal, and then it enters into the adductor hiatus and goes into the posterior part of the leg, becoming the popliteal artery. This popliteal artery will give off geniculate branches to the knee, and then it goes down and gives off the anterior tibial artery, which pierces the fascia here, comes into the anterior compartment of the leg, and goes down to become the dorsalis pedis. And it also gives off the posterior tibial artery, which winds below the medial aspect of your medial malleolus. And then it gives off the plantar arteries, the lateral and the medial plantar arteries. Those arteries will form the deep plantar arch with a branch from the anterior tibial artery. And then you have the peripheral artery, which also goes here, gives off some nutrient arteries to the fibular bone, gives off perforating branches, and also forms some anastomosis with the posterior tibial and the anterior tibial. So basically, we're going to focus more on the iliacs, the femorals, and the runoffs. This is the angiographic anatomy, just to make it easy. We divide, in peripheral vascular disease work and endovascular work, we divide it to 3 compartments. You have the aortoiliac. Can you guys see from here? Okay. You have the aortoiliac segment, okay, which is your iliac from the abdominal aorta to your iliacs. You have your femoral popliteal, which is your femoral, your superficial femoral arteries and your profunda. And then you have the tibial peroneal trunk, or the tibial peroneal part of it, which is the runoff below the knee. So basically, from here into your waist, from your waist to your knee, and from your knee to your feet. So let's talk real quick about atherosclerosis. So what happens is there's an injury to the endothelial lining of the muscle of the vessel. It will cause some activation. This will increase permeability to the intimal layer. You have some leukocyte adhesion, and then intimal lipid accumulation, which forms your foam cells. This will activate your monocyte attractant protein number 1 and your VEGF, which is a vascular endothelial growth factor. And all this with the oxidized lipoproteins and the foam cells will cause smooth muscle proliferation and migration, which will eventually cause plaque development in the vessel. So, let's talk about the prevalence. How big is this problem? It has been estimated that peripheral vascular disease affects over 250 million people worldwide. Okay? In the US alone, 12 million Americans are affected. Now, in Nigeria, there's no data that tells you the exact amount, but I can tell you what it is. I think it's like 19 million people. You know why? There's a study that was done that shows there's a 24% prevalence rate in hypertensive. Now, this is a study. There's a 24% prevalence of PAD in hypertensive patients. We know that the prevalence of hypertension in Nigerians is 30%, right? Nigeria, we have 240 million people. 30% of that is 80 million. 24% of this will give you 90 million. Okay? So that's 90 million people in Nigeria living with peripheral vascular disease. Now, this is a very nice study that was done by Eli and his colleagues, and I like the fact that they talked about, they divide them into peripheral vascular disease, either present or absent, and they talk about the symptoms as well as the examination. But what I want you to focus on is, they took diabetic patients, and they looked for the prevalence. Now, 52% prevalence in diabetic patients. So more than half of the diabetic patients that you're going to see in your practice will have peripheral vascular disease. Now, how many of them will present to you with intermittent claudication? 25% of them. So a lot of them are not going to present with the typical intermittent claudication, right? Now, if you're going to focus on presence of pedal pulses, you're going to miss a lot of this patient because you only have 11% of patients that have absent pulses. So a lot of them are going to have pulses. But it doesn't mean that because they have pulses, they don't have peripheral vascular disease. So I don't want you to use this as a discriminator to find out who has peripheral vascular disease. That's why I'm bringing up this graph over there. Now, the prevalence of PAD increases with age. Now, the previous study that I showed you, they found that if you're over 35, if you're over 55, your prevalence goes up by 30%. Below 55 is 15%, okay? But as you grow older, then the prevalence goes high. Now look at this, 85 patients that are 85 years or older, almost 60% of them have peripheral vascular disease, even if they don't have any symptoms. Okay, so we took care of a patient the other day, 89, was an 89-year-old male, and he had significant peripheral vascular disease. All his below the knee were all blocked off, okay? And he had an ulcer. So people that are 85 years or older, 60% of them are going to have peripheral vascular disease. Now, let's talk about the epidemiology of the disease itself. It's a multifactorial and multi-bed disease, meaning it shares the same risk factors with cerebral vascular disease, which is stroke, coronary artery disease, they all share the same thing. Look at this. In your PAD patients, 10% of them are going to have a stroke. 10% of them. 40% of them are going to have coronary artery disease. So almost half of your patients that you're treating for peripheral vascular disease are going to have coronary artery disease. It means you have to screen them for coronary artery disease. And you can see this is a 15% of them will have either of coronary artery disease, cerebral vascular disease, and peripheral vascular disease. That's very, very important. And they share the same risk factors: smoking, tobacco use, diabetes, and high blood pressure. Again, this is a relative independent risk factors. Diabetes is the strongest risk factor, okay? A patient with diabetes has a fourfold chance of having peripheral vascular disease. Smoking is next, hypertension is next, and hyperlipidemia. And there's a synergistic effect of these risk factors that you're going to see in a minute. Now, this is a very important study. It was a partner study that was done in the United States. They went to physician offices, looked over 7,000 patients. 7,000 patients. These patients did not have any symptoms. They were at-risk patients, okay? Patients over 70 years old, patients between 50 to 70 with a history of smoking or diabetes, but they did not have any symptoms. Guess what? 30% of those patients were diagnosed with PAD. That means that, Dr. Okogo is doing a wonderful job at the Badero area. That's where they have the outpatient praise. 30% of the patients that you see, Dr. Okogo, in that Badero, they have peripheral vascular disease. So you need to be telling your medical doctors to be screening patients with an ABI. If a patient comes to you 70 years or older, even if he has no symptoms, you need to do an ABI. If a patient is over 50, has an issue of smoking or diabetes, you got to do an ABI. Now, if a patient is less than 45, has diabetes with one of the risk factors, you have to do an ABI. You're surprised how many people you're going to catch. Disease. So when you combine smoking with high blood pressure, with dyslipidemia, with diabetes, they all come together. They're like brothers and sisters. They work together. All right. So let's move along to how these patients present. Most of them are going to have no symptoms, asymptomatic, okay? And some of them will have intermittent claudication. What is claudication? They walk. After some time, they get tired or they get pain in the leg. They have to stop and gather themselves, and the pain goes away. Sometimes they have functional impairment. They start having gait disorders. They start to overcompensate. And then it progresses to what we call ischemic rest pain, where they have pain all the time, especially at night. They tell you when I'm asleep, or when I'm laying down, I have pain. And then it starts to get ulceration and gangrene. A lot of times patients present when they have ulcers, okay? And when they have ulcers, it's almost too late. Although we can still do a lot, but you want to catch them at this area and try to prevent the progression of the disease. Again, for peripheral vascular disease, it's very, very akin to coronary artery disease. The cardiologists that are here, I see them here, Dr. Adebayo and Dr. Songwa, in your coronary artery disease patients, some of them are chronic stable ischemia. We talk about chronic stable ischemia. So these patients have chest pain, okay? But the chest pain comes and goes and comes and goes. That's chronic stable ischemia. And then you have your acute coronary syndrome. Acute coronary syndrome can be divided into non-ST elevation MI, ST elevation MI, and unstable angina. That means the chest pain is getting worse and it's occurring at rest. The same thing with peripheral vascular disease. You have chronic stable limb ischemia. So these patients will have claudication or no symptoms. And then it's going to get worse to what we call critical limb ischemia, where they have rest pain, like I mentioned all the time, with non-linear ulcers and gangrene. And then sometimes they can have acute limb ischemia, which is similar to your ST elevation MI, where they have symptoms less than 14 days, and the limb is dying, and this is an emergency. You have to take care of it. Now, again, like I mentioned, patients are going to present with atypical symptoms. I've already talked about the typical symptoms. Atypical symptoms, they might have exertional leg pain, they might involve other areas, they may not stop. It doesn't still mean they don't have peripheral vascular disease. You still have to look at them because 33% of your patients are going to present with typical symptoms. Most of the patients will have atypical symptoms. So your index of suspicion has to be high. Now, how do you classify claudication? We've talked about all the symptoms. You need to classify the symptoms. There are two major classification schemes. You have the Rutherford and the Fontaine. This is one that a lot of us use in the United States. Sorry. The Rutherford is the more common one, okay? So it's from 0 to 6. 0 is your asymptomatic patients, like I told you, most of the patients that you're going to see. Grade 1 is minor claudication. Grade 2 is moderate. Grade 3 is severe. 4 is ischemic rest pain. Ischemic rest pain, no ulcer, no ulceration. Grade 5 is minor tissue loss, and I'm going to show you in a minute. And then grade 6 is ulceration and frank gangrene. So whenever you see a patient, you have to say Rutherford class, whatever it is, so that whoever is taking care of the patient knows exactly what to expect. Now, claudication, like we've talked about, is the tip of the iceberg. I want you to, this is a very, very important slide. Anytime you see a patient with peripheral vascular disease, you have to look at, separate them into two things. They have cardiovascular risk as well as peripheral vascular risk. It's not just the leg. There are many things involved. So these patients that have peripheral vascular disease, if you follow them over 55 years old, they come with intermittent claudication. In 5 years, 30% of them are dead if you don't do anything. 30%, a third of them are dead with intermittent claudication if you do nothing. Guess what? 20% of them will have non-fatal MI or stroke. So 50% of those patients that come with claudication are going to have either stroke, MI, or they're going to be dead. All right? Now let's look at the vascular outcomes. 4% of them are going to have major amputation. 4% of them. 7% of them are going to have a bypass. And 16% of them are going to have worsening claudication. So every time you see your peripheral vascular disease patients, you have to do a cardiac evaluation. I see a lot of patients, they refer for ulcer or claudication. There's no evaluation. There's no echo. There's no stress test. Nobody ever checked their heart. And you have to check their heart because 50% of them are going to have a stroke, MI, or going to die if you don't do anything. Now, this is a very important slide. What is the impact of PAD on mortality? Look at this. In 10 years, okay, in 10 years, even if you have no symptom with a large vessel PAD, 50% of them are dead. No symptoms. And if you have severe symptoms, more than 75% of them are dead in 10 years. So this is divided into asymptomatic patients, symptomatic large vessel PAD, severe symptoms. But look at that. This is the impact of CAD on mortality. I'm keep stressing this so that we can see that. Now, patients with PAD, 6 times the risk of dying from cardiovascular disease, 2 times the risk of stroke, 4 times the risk of fatal MI. Remember that pie chart that I showed you earlier? This is exactly. So anytime you see a patient with PAD, they have a 6 times greater risk of dying from cardiovascular disease. Again, what happens to those patients when they're going through procedures? Some of the patients are going to get bypass surgery, or they're going to get a PCI, maybe at Lagoon or somewhere. Guess what? When you have a history of PAD, your risk of dying or having an MI or stroke during bypass is almost double that of patients that don't have peripheral vascular disease. The same thing if you're going through PCI or getting a stent in your coronaries and this patient has PAD, your risk is almost like 30% higher than somebody who doesn't have peripheral vascular disease. Again, look at this. What is the prognostic importance of PAD in patients that are undergoing coronary vascularization? So either they're getting PCI or bypass surgery. It doesn't matter whether you have symptoms or no symptoms. Once you have PAD, your 5-year mortality is 14%. Just having PAD, whether you have symptoms or not, is very high when you're going through any procedure. All right, I think I've talked a lot. This is the last slide on this topic right here. What happens when these patients present with acute MI? So what happens when you see a patient that's presenting with acute ST elevation MI and he has a history of PAD? You can see this Kaplan-Meier curve, okay? These are patients with history of peripheral vascular disease. You can see their survival. In 1 year, their survival is almost, you have almost 12% of them are dead. The survival has gone down, 88% when they present with an acute MI in those patients. So let's peel off the curtain now. Now that we've talked about how these patients present, let's dive into what we like to do, which is examine the patient. So let's go and examine your patient now and see what happens. All right, so remember, you have to have a comprehensive vascular exam. You have to check the carotids. I'm sorry, let's go back here. Make sure you check the carotids, check the subclavian, check the blood pressure in both arms. If you have a difference in 15 to 20 millimeters of mercury, that's indicative of subclavian artery stenosis. Check your posterior. Take off the socks, okay? You got to take off the socks and examine these patients. You can't just look at them through the socks. Take the socks off and check for the pulses, okay? You got to check the dorsalis pedis and the posterior tibial pulses. And there's a universal language. So you don't just say, oh, pulses are absent. You got to say 0 is absent, 1 plus is diminished, 2 is normal, 3 is bounded. So you might say 2 plus pulse, like our patient had a 1 plus pulse, which is diminished. So in your writing or your medical write-up, you say a patient has a 1 plus, 2 plus, 3 plus, okay? Now, these patients have dependent rubor if they have critical limb ischemia. What is dependent rubor? You raise the leg at 60 degrees for a minute, and you put it down. The color should come back in 10 seconds. If it takes longer, like 40 seconds, that is a critical limb ischemia. That's a patient that is going to get amputation in the next 1 year if nothing is done. And this is what it looks like. This is elevated pallor. You can see once the leg is elevated, inside how pale it looks. And when they dangle their legs, a lot of these patients that have critical limb ischemia at night, they dangle their legs because the blood has to go back to the leg. This is minor tissue loss, and this is frank gangrene. So in your coronary artery disease patients, we check the EKG, we check echo and the stress test, and you do the cardiac angiography. It's the same thing with peripheral vascular disease. Your EKG is similar to ABI. So we start with an ABI, which is an ankle brachial index, and I'm going to tell you what that's in a minute. And then your echo is similar to your pulse volume recordings or your segmental pressures, which are non-invasive testing. And then sometimes you have to do a stress test on these patients. People ask, why would you do a stress test? Not a stress test of the heart, but stress test of the leg, and I'm going to show you in a minute. So this was something that we published years ago where ABI was used to predict 3 vessel disease and left main disease in African American patients. Can you imagine that? ABI, just having an abnormal ABI predicts whether this patient is going to have left main stenosis or triple vessel disease. Okay? And the sensitivity was 77%, 85% sensitivity and 77% specificity, which is pretty close because ABI in itself has a 95% sensitivity and a 99% specificity, which you can see. I'm going to show you. So how do you calculate the ABIs? The ankle systolic pressure over the brachial systolic pressure. I'm going to show you in a minute. Remember, this is what I told you about. It's very, very sensitive and specific. The normal is 1 and above, borderline 0.9 to 0.91 to 0.99. PAD is diagnosed when you have less than 0.99. Sometimes the arteries are non-compressible, and you can have an abnormally normal. It's extra normal, pretty much, like 1.4. It doesn't mean it's normal. You still have to check that patient. I'll tell you what it means. Patients that have less than 0.4, you know that they have critical limb ischemia. Those patients need to be taken care of right away. So I've given you a little example here. So you take the higher of the blood pressure, so it's 100, 120. This is what you're going to use as your numerator. And then if you check your dorsalis pedis and your posterior tibial with the higher of the two, you use it the higher of the blood pressure. So for example, your right ABI, you're going to take the higher of the posterior tibial or dorsalis pedis and divide it by the higher of, it doesn't matter if it's the left or the right, okay? So in this case, the right ABI will be 68 over 120, which gives you 0.57. That's abnormal. And the left, you take the higher one, which is 136 over 120, which is normal on the left. So this is a class 1 indication in the United States. ABI must be used, like I mentioned, those patients above 70, 50 to 65, 69 with diabetes, hypertension, less than 45 with diabetes and another risk factor, or any patient that has atherosclerotic disease somewhere else. In carotid, subclavian, renal, they all work together. Now, after you do the ABI, you can do your pulse volume recording, and this is what it looks like. You have the normal aortic pressure, which is, you have the upstroke with the dichrotic notch and the downstroke. This is what the normal one looks like. The mildly abnormal one, the dichrotic notch is gone. The moderate abnormal one, the peak systolic pressure goes down. Severe abnormality is basically flat. And if you have a patient, for example, who gives you a good history of lower extremity claudication, and then you check the ABI, and the ABI is normal. Don't stop there. Exercise the patient. Tell them to walk around and repeat the ABI. And guess what happens? Normally, your brachial pressure will go up, but your ankle pressure will go down. And then you can see this patient, after we exercised, it went to 0.3 from 0.68. This was normal, 0.95. After exercise, went to 0.6. So don't stop. If you have a high index of suspicion, exercise these patients. Duplex ultrasound is another way that we use to check, and this is what it looks like. You have your good spectral flow, laminar flow. There's no turbulence here. Now, with patients with PAD, you're going to see turbulence. You see this turbulence right here? And then you can check the peak systolic volume, peak systolic velocity. And this peak systolic velocity, I've given you the cutoffs here. If it's over 150, it's indicative of a 50% stenosis. Once you have a doubling, like a 300, then you know you have a significant hemodynamically significant stenosis. Transcutaneous oximetry is also something you can do with patients that have ulcer. We tell them in patients in wound care, you can check this. This will tell you if the ulcer is going to heal or not. So you put an electrode, on the skin, you measure the oxygen levels. If it's less than 25 to 30 milligrams of mercury, that means the wound is not going to heal. So don't even waste your time. You can still, take care of the wound, but you know that wound is not going to heal because the normal is 50 to 60. So I know this is a busy slide, but I'm going to make it very simple. So this is the algorithm when you see a patient. You see a patient that is suspected PAD, you take your history. The history is in keeping, you check your ABI. Okay, if it is high, if that ABI is extremely high, like 1.4, you need to do what is called a toe brachial index. Okay, the same thing like you do into the inside of the ankle, you do it in the toe. If it's less than 0.7, then you need to revascularize that patient with optimal medical therapy. If it's greater than 7, then the patient doesn't have peripheral vascular disease. If it's normal, like I mentioned before, you still have a high index of suspicion, you exercise that patient. If it's abnormal, the patient gets revascularization. And if it is an abnormal ABI, you need to either start optimal medical therapy and consider revascularization for this patient. Now, let's go to the imaging. Now, this is a CTA. This is what a CTA looks like. You can see this patient has an aneurysm, okay, right here. If I'm moving too fast, please let me know. I don't have a lot of slides. This is what a normal MR angiogram will show you. We can do this also in Legali because we have an MR there. And this is a normal MRI of the lower extremities. This is what an abnormal MRI looks like. You can see the superficial femoral artery right here. This is a profunda SFA. This is a chronic CTO, chronic total occlusion of bilateral SFA, and it reconstitutes in the popliteal area. You can see this. This is where the little collateral feeds the artery back. Okay, and this is what an angiogram looks like. This is what we do in the cath lab. Okay, this patient has a chronic total occlusion of the left SFA right here, and he has a significant SFA lesion on the right. So what are the therapies? Now that you've diagnosed, you've done a wonderful job to diagnose this patient. How do you treat these patients? The therapies are classified into two. There are therapies that will prevent MI and stroke. Remember we talked about this cardiovascular risk. You give them antiplatelets, and I'll tell you which ones. And cholesterol-lowering statins is also a must because we know that oxidized lipoprotein is one of the etiology. ACE inhibitors have been shown to help as well. And then therapies to reduce symptoms. Now, to reduce symptoms, exercise, graded exercise therapy is good. Cilostazol, I'm going to show you the study, the data, endovascular or surgical interventions. Now, if a patient comes with critical limb ischemia, you're not trying to reduce the symptoms, you're trying to save the limb. And you have only two options, endovascular or surgical therapy. Cilostazol, okay, it's a class 1 indication in a patient that has claudication. 100 milligrams twice a day to improve symptoms. It's contraindication indicated in patients with CHF. So don't give it to your CHF patients. Any patient with an ejection fraction less than 60% or that has preserved ejection fraction with diastolic dysfunction. But this is class 1 indication in the United States. And this is a study. Before we're using pentoxifylline, okay? And then this study, checked basically between cilostazol and pentoxifylline. You can see the difference here. So it's the only drug that's been proven to improve walking distance. So you can start by giving your patients this medication and the walking distance will be improved. They might have some GI side effects like diarrhea. So just take that into consideration. All right, so I've talked about this. For patients with claudication, the outcome is to patency, critical limb ischemia. You need to save the limb, not patency. So again, this is the class 1 indications and guidelines for the management of patients with peripheral vascular disease. Endovascular procedures are indicated. If they have lifestyle limiting claudication that has limited the lifestyle, then you can start with endovascular therapy. And that's the class 1 indication with the American College of Cardiology. Now, these lesions can be divided into 4 categories. This is a task classification, the Society of Consensus. There's a type A lesion, type B, type C, type D. Type D lesions go to surgery, okay? These are long, diffuse lesions everywhere. They're calcified, they're bilateral. those patients are better served with surgical techniques. These focal lesions, more endovascular. Type B lesions, like moderate diffuse lesions, you can still do them endovascularly, but once you start getting the type C or type D lesion, that's a surgical case. Dr. Kuyo, remember the patient that we last saw? I was telling you there's a type D lesion. It was a complete occlusion from the knee all the way to the foot. That kind of patient you want to send for surgery. Now, so we're going to go to the aortoiliac occlusive disease, surgery versus endovascular, okay? Excellent long-term patency rates. When you use vein conduits in surgery, the patency rate in 5 years, 90% is equivalent to endovascular technique in the aortoiliac region. The only problem is you got to remember this, is surgery, you have a 1 to 3% mortality rate, which you don't have in endovascular technique, which is why some of these patients, you need to start thinking of endovascular first before you do surgery. And this is a patient that was treated endovascularly. You can see the bilateral common iliacs treated endovascularly. Now, the common femoral, moving down now from the aortoiliac region, we'll go to the common femoral. The common femoral area we reserve for the surgeons. We do not like to fix it endovascularly. You want to stent that. That is a surgical place. But this is a study that was done recently that shows that there was really no difference whether this patient got surgery or got endovascular technique or stenting. Again, like I mentioned, even though this study was great, that shows there's no difference, we really don't like to touch the common femoral artery. Just send it to the surgeon, let them do endarterectomy in the common femoral. So we move along to the superficial femoral. This is an artery that has been abused in the body, okay? It undergoes torsion, contraction, flexion. You're playing football, you know. I know Dr. Unino likes to play some kind of sports. You know, you're jumping, you're doing basketball, you know, he's always looking fit. So it goes through a lot of abuse. So it's exposed. Now, what happens when you compare surgical to endovascular technique? With the surgical technique, the patency rate in 5 years, 40 to 75%. In endovascular technique, you have more patency rates in 1 year. Again, this is the Achilles heel of surgery, 1 to 3% mortality. So these patients, endovascular first. Now, what kind of, if you use a vein bypass, you're going to have like a 74% patency rate. That's a good thing about surgery. Surgery is good if you have a vein. If you do not have a vein and you're using a PTFE graft, this is what you get, 39% patency rate, which is nowhere compared to endovascular technique. So if you're going to do surgery in any of these patients, you have to make sure that you use a vein, autologous vein bypass. Now, with the endovascular technique, we started with PTA, which is plain balloon angioplasty, and then we realized that stenting, just like in the coronary arteries, stenting is better because you limit your restenosis rate with stenting. Angioplasty by the stenting, stenting always wins. And these are the kind of stents. You have the balloon expandable stents or the self-expandable stents. Now, this is a drug-coated balloon, which also came after. You know, people said, okay, well, you know, using just plain old balloon, why don't you put drug in the balloon? Let's see what happens. So this is the 2 trials that was done in a patient that had paclitaxel, a drug-coated balloon. That's the IMPACT trial. You can see the primary patency was higher in those that have drug-coated balloons. And we have drug-coated balloons in the Wilson Lagoon Hospital, by the way. So you can always use drug-coated balloon. This was a Thunder trial, showed the Kaplan-Meier curve. Patients that got the drug-coated balloon did better with patients that just got a regular balloon. Now, what about drug-eluting stents? Okay, that also came out. Zilver stent, this was a study that showed that with patients that got Zilver stents, you have primary patency of 75% with your drug-coated stents. So drug-coated stents also better than regular plain old stents. The other evolving techniques, we have atherectomy devices that we use in America. We don't have them in Nigeria yet, okay? There's a laser atherectomy, there's directional atherectomy, optical atherectomy. We use this a lot. You use this when the patient has calcified lesions. There's a lot of calcium in the lesion. So you use this to shave off the calcium, because if you don't and you just use your balloon, you can rupture the vessel. But if you don't have it, there's still ways that we can get around it. But in the US, we use this to kind of shave the calcium so that your stents can expand fully. And these are studies that have been shown, that show, you can see here the primary patency rates when they use atherectomy devices, very great. All right. So let's summarize all this conduits that I talked about. Vein, when you do a bypass, this is a 75% 5-year patency rate is good. If you use a graft, like for example, the patient that gets a coronary artery bypass graft that also has peripheral vascular disease, the surgeons are going to use the vein graft to bypass the artery. That means there's no vein to use for the legs. So if they use a PTFE graft, the patency rate is not good. So that kind of patient should go endovascular first. Stents, 70%, jugular stents, 75%, atherectomy, 80%. So these are all endovascular techniques which will give you 70 to 80%, which is comparable to what you get with an autologous vein bypass surgery. Again, type D lesion, as you move away from type A lesion, surgery first. As you go towards the type A first, the lesions, endovascular first. So you can see here, the longer the lesions goes through surgery, the shorter the lesions goes through endovascular first. Now, what happens after you've done your wonderful intervention or bypass surgery? How do you take care of these patients? You got to put them on antiplatelet therapy. You got to continue aspirin indefinitely. You have to put them on Xarelto or rivaroxaban, 2.5 milligrams twice daily. I'm going to show you the study now. This is standard of care now anywhere in the world. You got to put them on 2.5 milligrams Xarelto. Now, if they have to have clopidogrel, maybe they got a stent in their heart, make sure you give them clopidogrel or Plavix for only 30 days. After 30 days, you stop it. Keep them on the rivaroxaban and the aspirin alone and do follow-up. So this is a study. This is the Voyager PAD study that was done that looked at, those patients were, I think they were close to 6,564 patients. They randomized those patients to placebo or rivaroxaban at the dose of 2.5 milligrams twice daily. And you can see there was a 15% relative risk reduction in those patients that got rivaroxaban. So this was one of the studies, the pivotal study that has made this a class 1 indication now. A 50% relative risk reduction in those patients that got rivaroxaban. Now, this is a COMPASS trial. This COMPASS trial, they used a lot of patients. It was 25,395 patients. Okay, it was a multi-center trial in the UK. And they randomized those patients into 3 arms. So the one arm got just aspirin alone, the other arm got rivaroxaban 5 milligrams twice a day, and the third arm got rivaroxaban 2.5 milligrams with aspirin. And there was a 25% relative risk reduction in the primary outcome of major cardiovascular death, MI, or stroke in those patients that got rivaroxaban and aspirin. So, and this patient had a history of coronary artery disease or peripheral vascular disease. In the Voyager PAD trial, these were patients that got left extremity revascularization, and then they randomized them. So both of them, whether the patients have coronary artery disease or not, there's a risk reduction in cardiac events as well as limb events. And it doesn't matter whether these patients were on clopidogrel or not, okay? You can still hear the absolute risk reduction here is 2.8. So if you do the calculation here, 18.7, 21.5, that should give you around 13% relative risk reduction in these patients, okay? So when you have a patient that have peripheral vascular disease, you want to do revascularization, you want to fix the inflow first. Remember, the inflow is the aortoiliac segment. You want to fix the iliac first and see if the patient improves. If it doesn't, then you fix the outflow. So we divide them into inflow and outflow. You want to fix the inflow first, and then you fix the outflow. Now, if the patient has chronic critical limb ischemia, you have to do everything. Do what we call the inline flow to the leg, because you want to save the limb, not just symptoms this time around. All right, so this is the final phase. You guys have done a great job already. So we're going to talk about critical limb ischemia. Remember, this is like acute coronary syndrome. These are the patients with ulcer, gangrene, all that. 20% of these patients are going to be dead in 6 months if you do nothing about it, okay? And 35% of them are alive with amputation. So something's going to happen to 50% of them. Only 45% of them are alive without amputation, okay? Remember this concept. Any patient with ulcer needs 6 times the blood flow for the ulcer to heal. So if you don't fix it, the ulcer is not going to heal. That's why you have to revascularize these patients. Look at this. In critical limb ischemia, 1-year outcome, 25% of them are dead. Like I mentioned, 30% of them have amputation. Only 45% of them are alive with 2 limbs. And 20% of them will progress anyway. I've told you the goal. When you have critical limb ischemia, just like what we do in cardiology now, we do what is called a multidisciplinary team, a heart team approach. Talk to your surgical colleagues. This is not a surgery versus cardiology. We all work together for the benefit of the patient. So talk to your surgical colleagues. Some of the patients might benefit from surgery or endovascular technique. You want to give the patient the best technique possible, okay? This is a case that we did at Iwosan Hospital. This is actually the first reported case in the history of Nigeria. This was a patient that had critical limb ischemia that we did. It was a case I did, we just published with Dr. Kushimo, came from Luther, was training with us. And this was a patient that had critical limb ischemia. He had a chronic total occlusion. They brought him from another state and were able to save the leg with endovascular technique. And you can see here, this was his left superficial femoral artery was completely blocked. Okay, and I was able to get it open. This was me trying to get it into the limb, the CTO. This was chronic. This was a CTO. We got in. We fixed it, and you can see a nice result. He also had a popliteal artery that was blocked here, which we fixed, and we reported this case as the first that was done in Nigeria as a limb salvage procedure endovascularly. Now I'm going to talk real briefly about angiosome. This is a concept that we use now. So the leg is divided into some angiosome area based on the blood supply. If it's the anterior tibial artery or the salus pedis, is your front part of your leg, the dorsal part of the leg. Posterior tibial is the plantar area, and the peroneal artery is toward the leg. So basically, if you have an ulcer in this area, and a patient has a blockage of anterior tibial artery and the posterior tibial artery, you want to fix the anterior tibial artery. You don't want to be fixing the posterior tibial artery because it doesn't supply the area of the ulcer. If the ulcer is in the lateral aspect of the leg, you want to fix the peroneal artery. So you want to do what's called a directed therapy to that patient. Pedal access is something that we use sometimes when we want to access the leg. If the place is blocked and you can't go from top, sometimes you can go to the bottom, and you can see we're able to revascularize this patient, the anterior tibial artery going through the pedal. And there's a study that was shown 100% technical success rate with pedal access. So it's something that you have to have in your armamentarium when you're treating these patients. Now I'm going to talk about two trials that compared surgery with endovascular technique in patients with severe ischemia. This was the first study that was done in 2005 that compared both of them. Now, there was no difference, okay, in amputation-free survival and overall survival. Okay, it was 71% in the surgical arm and 70% in the endovascular arm, and death from any cause was almost 57, 51, and 52 in both arms. So no difference in patients when you do endovascular technique versus surgery in these patients. And they used, I think it was 452 patients in that trial, and no difference at all. Then there was a Basel II trial that was done 15 years later. So this Basel II trial, basically it used the vein, the best surgical technique versus the best endovascular technique. The best surgical technique is vein bypass versus the best endovascular technique, maybe stent or maybe atherectomy. And you can see here, big difference. The endovascular treatment group did much better. So based on this study, it was now deemed that you need to do endovascular first. You can see what it says here, revascularization becomes for a best endovascular treatment first revascularization strategy. It suggests that more patients with chronic limb ischemia, with or without additional proximal, should go for endovascular technique first. And again, the general principle we've talked about, critical limb ischemia, you're going to save the leg, claudication, you're going to restore symptoms. Now, let's talk briefly about surgery. Basically, surgery, what base surgery is going to do is the bypass, okay? So you have a FEMPOP bypass, 80% 5-year patency rate. Remember, when you use the vein, when you use PTFE graft is lower, the mortality is higher, and this is what it looks like. This is the patency rate. We've talked about this. This is what it looks like. You're going to get this scar, okay, when you have surgery. Although, like I mentioned, with the vein, you're going to get good patency rate. But sometimes patients don't want a scar. They want to try endovascular first. And how many types of surgical bypass? You can have the aorto bifem. You can have the femoral popliteal bypass, or you can have the femoral crossover bypass. Again, 5-year patency rate, 6-7% for this. Extra anatomic, sometimes you can't even bypass that. You have to go from the axillary. This is an axillary bifem bypass. And the patency rate is 13% when you go extra anatomic, and then the mortality is higher, 19%. Okay? But this is something that you have to do. So, And then you can have graft failure within 30 days. That's due to the technique. If it's within 2 years, intimal hyperplasia, late failure after 2 years progression of the disease for the patient. Now, this is the in thing now. It's called a percutaneous transluminal arterial bypass. So we now, endovascularly, we can bypass, we can do the surgical bypass without having to open the patient up. And I did a case recently, it was a very great case. So basically what happens is this patient has a superficial femoral artery that is chronically blocked, okay? So you're gonna create a fistula. Proximally, you're gonna enter into the vein, into the femoral vein, and you're gonna come back out distally into the popliteal artery, and you're gonna put a stent through, so you're gonna bypass the whole thing without having to cut the patient open. And this is what it looks like. I don't know if there's a volume. I apologize. Looks like we're having some technical difficulties. I don't know why it's not playing, but all right. Well, is it frozen or something? Okay. So this stent, this is a covered stent, is called the Toro stent graft, and then the device is called the endocross. So you pass a snare from below into the vein, and you bring this device here. It's got a needle. Okay, you turn it. You open. You deploy the needle. Once you deploy the needle, the wire comes in here. You snare the wire. You catch the wire and bring it all the way down. The next thing is you put a balloon here. It's usually a forward balloon, and you dilate this tract. Once you dilate the tract, then you take the device back and bring it all the way down into the vein. Now you're in the vein. You repeat the same step here. You deploy the needle. Then you put the wire down. Now you've got a floss. So now you start deploying your stents, coming from top to bottom. You make sure there's a 6 millimeter overlap. And now you have your bypass. And the patient goes home the next day, no cut, no general anesthesia, no scar, nothing, okay? So I'm going to show you a case that I did very quickly. There are some things that you need to do. You can see this patient has a chronic occlusion of the superficial femoral artery here. You can see where it comes in back. And I was able to do it, and you got a nice bypass. You want to make sure that the vein is 10 millimeters and above, or the patient has a duplicate vein, because you don't want to have DVT. You also want to make sure that this patient has a 2-vessel runoff, okay? And this is very nice results. And this is a detour trial that was done that shows that those patients post-procedure freedom from target vascularization was good. DVT was low, stent thrombosis was good. There was very few stent thrombosis, okay? And now it's something that everybody's using. You can see here, freedom from stent thrombosis, freedom from, amputation-free survival, primary patency rate, everything looks good. So again, in summary, PAD is common. We got to treat even if they have no symptoms. Focus on risk modification. Remember the heart, remember the heart, remember the heart, okay? And exercise therapy, drug therapy, revascularization, critical limb ischemia, you got to see the limbs. And now let's dive and fly into some nice cases, okay? As a way to finish off this nice presentation, these are some of the cases that I've done. Okay, just to kind of tell you what we do with endovascularly. This was a patient that came to me in the US, and you can see the common iliac is completely gone. 95% of these patients are going to get bypass surgery. Most endovascular doctors will not touch this because it's very dangerous and highly critical. But I was able to put a stent. You can see here, we put a stent. I had to do an intravascular lithotripsy because it was a very calcified lesion. And we shock wave lithotripsy to kind of open the artery. I used the command ES wire with a Navicross catheter, and it was able to get in, and we had a very nice result, brought all his internal iliac artery and everything better, and he did fine and went home the same day. Another patient here, you can see, iliac is completely gone. I had to reconstruct the whole iliac with this stent, and everything was a very nice result. Now I'm going to play you what it looks like when we're doing. This is a patient that had external iliac artery stenosis. You see the blockage right there? So I had to cross over from the left, came onto the right, and you're going to see he was deploying a stent here. Now you see this stent being deployed. You can see it's going to see now it's expanded. And the final angiogram, you can see much nicer, completely gone. This is a patient that had common femoral artery stenosis. Again, remember I told you we don't like to put a stent. I had to do atherectomy here. I had to shave off the calcium, and you can see it's almost 99% better, right? We didn't have to put a stent in this patient, and this patient didn't have to go through surgery. This is another patient. You can see the SFA is completely blocked here, completely all the way to the foot. All the way to the knee. And I had to open this up. And now you can see it's all the way now. This case probably took me like an hour and a half to fix. Now you can see here, see the profunda femoris arteries, the occluded SFA completely gone. And once we put in the stent and revascularized it, everything came back. Okay? This is sometimes very tough to do because you can't even see where you're going in this patient. This is a patient we did in Laguna Hospital. You can see the popliteal artery. Over here, very calcitrant lesion. We fixed it, we put a stent, and he did very well. This is a patient that had runoff. This is anterior tibial, this is the peroneal and posterior tibial. Both arteries are completely gone. And I had to do an atherectomy, basically reconstructed the whole arteries from the knee to the foot. And you can see nice results here, all the way down. Same thing here, look at this patient. Basically had no runoff to the foot. Everything is completely gone in this patient. And I was able to revascularize everything and reconstruct everything endovascularly, and he went home the same day. This is another patient. He had the tibial trunk completely gone. This patient had an ulcer, and we had to reconstruct. We were able to get 2 of the arteries back, and this is very difficult because when you're trying to get in here, you can shut everything down and convert this into acute limb ischemia. This is another patient. You can see he doesn't really have anything towards the foot. The arch is gone, and we have to reconstruct it. Now he has the pedal arch, and he has blood going towards his foot. So thank you for your attention. Basically, I know you guys have been good audience, but again, I just want to make you understand this is not a surgery versus endovascular technique. We're here to partner together, and I want you to remember, Laguna Hospital is here. You can send your patients. Remember, you have to, evaluate this patient when they come to you, check the ABI. If they have don't wait for them to have an ulcer. Send them to us. We'll take care of them. We're here to help. We're here to partner with you. The surgeons are also here, too, to help. This, sometimes you can't do it endovascularly, but the thing is to give these patients a trial of endovascular. If it fails, then you can always do surgery, because surgery is always last resort. So just remember that we're here. I hope this will help change your practice pattern, and know that you have a lot of support. Thank you for your time.
Another round of applause for Professor Badero. Thank you, thank you, thank you. Thank you, sir. Thank you, sir, for that powerful and enlightening presentation. You've not only unpacked the complexities of peripheral arterial disease and its devastating consequences, particularly in Nigeria, but also challenged us as clinicians to think proactively about prevention, early detection, and timely intervention. Your insights remind us that amputation should not be the inevitable outcome, if that has become for so many, but that when we work together, collaborate together, patient education, and advocate adequately, we can turn the tide. Now, before we go into the question and answer session, of which we have 15 minutes for that, and then, of course, we can ask other questions during the tea break and network a bit, I would just like to recognize someone very important in our midst. It is my absolute pleasure to warmly welcome Mrs. Fola Laoye, a distinguished leader. Please, that applause is not taken. That is my Oga Pata Pata. Yeah, that applause needs to ring. The room needs to shake. Thank you very much, yes. A distinguished leader whose vision continues to shape healthcare delivery in Nigeria. She's the co-founder. If you don't know her, I want to tell you. She's the co-founder and CEO of Iwosan Investment Limited, the parent company to the company I serve at, Iwosan Lagoon Hospitals, and a passionate advocate for health systems transformation. We are deeply honored to have you with us today, ma'am. Welcome. Yeah, so we go into the question and answer session. We have my colleague over there with the microphone. If you're ready to throw your questions at our esteemed speaker who has, broken peripheral arterial disease to pieces today, yes, we're ready for you. 15 minutes before we go for our tea break and a networking session. Please, the floor is yours. Give us a brief introduction and then go ahead with your question. Thank you very much.
Good afternoon, everybody. My name is Dr. Odeshwu. ICU Doctor Iwosan Lagoon Hospitals, Ikoyi. Thank you very much, sir, for this wonderful presentation and for opening our eyes. In your presentation, you talked a lot about diabetes, smoking, and hypertension as risk factors. I just want to ask if there is a role of this management for sickle cell patients who have chronic leg ulcers due to some kind of blood vessel insufficiency, and how that may be incorporated into this treatment. Thank you very much.
Excellent question. You see your name is Professor? What's your name again?
Dr. Odeshwu.
Well, sickle cell is something that is very dear to me. I lost my brother to sickle cell many years ago. So yes, they have ulcers, and if it's due to blockages, of course, definitely you can fix them. A lot of times in sickle cell patients, they also have necrosis of the femoral head. Basically they have poor circulation because of the blood vessels. Yes, but sometimes they have very tiny vessels. And you cannot do endovascular techniques sometimes when the vessels are very tiny, because the things that we use, the smallest balloon that I know is 1.5. And so the vessel is very, very small. Sometimes you just do medical management. And sometimes it's sickle cell patients, they have very, very tiny vessels. But if the vessels are big enough and there's a blockage, definitely endovascular first is good, because most surgeons will agree with you that for sickle cell patients to do surgery on them, they can be high-risk patients. So yes, I hope that answers your question.
All right. I'm Dr. Ayotola, representing Intron Health and Doha Health Services. So mine is the financial part. So what's the cost estimate for and then the vascular procedure? Estimate.
Very, very good question. I can tell you're from the financial sector too. But anyway, I don't know because I don't get involved with the financial aspect as a doctor. My job is to take care of the patient and treat them. I would leave that to the administrators of the hospital, the Dr. Inirons, the Dr. Kuyoros, the Dr. Okogos. They are very astute. They'll be able to tell you. But I can tell you one thing though, okay? The cost is comparative. And, what you gain, what you get is much more. The cost is comparative anywhere in this country, and it's much cheaper than going abroad. And Lagoon Hospital has done a wonderful job to make sure that this technology is available and it's affordable to a lot of the people here, okay? Because guess what? If you lose a limb, there's a loss of mobility. Even your production goes down. You're unable to take care of your family. You can't work. So, but to answer your question, I don't know the exact amount, but I can tell you for a fact, it is very comparable, it is very affordable. When you look at, the cost-benefit ratio, definitely something that, it's not as bad, okay? Thank you for your question.
Thank you very much for your presentation. My name is Pascal, and my first question is actually sequel to his, because the comparison I was looking at was endovascular versus open surgery. So I'd like to know, if the costs are comparable, it makes sense to go for endovascular first rather than open surgery. Then I was going to ask about pharmacological stress testing in chronic limb ischemia. I don't know if it's something that if the patients can't walk around, can we give them drugs to sort of do the stress testing for them?
So great question, Professor. What's your name again?
Pascal.
Professor Pascal, double P. Anyway, critical limb ischemia, you don't exercise those patients, okay? Because again, you're trying to save the limb. So you don't even need to do, you don't need to do any significant tests. Once the ABI shows that it's critical limb ischemia, that patient should get revascularization. So you don't need to, because your ABI is going to be abnormal. You can't have critical limb ischemia and your ABI is normal. It's impossible. And if you suspect it's critical, for example, if the patient has an ulcer, there's no point getting an ABI. Okay? There's no point. If the ABI is normal, what you're going to do, right? There's an ulcer. So to answer your question, the exercise ABI is only in patients with lower extremity claudication. Once you get to the critical limb ischemia realm, you don't need to do an exercise ABI in those patients because they have pain all the time anyway. So those kind of patients, you go straight to do an angiogram and revascularization because you want to save that limb. Remember I told you critical limb ischemia is like acute coronary syndrome. Right, in those patients, just not ST elevation, but you need to do something very, very quickly because if not, they can lose that limb.
All right, thank you very much, sir, for the very enlightening presentation. My name is Dr. Achala. I have 2 questions here. I'm working on a study on chronic threatening ischemia recently, and I'd like to ask about the role of statins in maintaining the patency of the blood vessels after revascularization surgery, if any, at all. And second to that as well is to ask about the risk for repeat limb ischemia if an intervention has been done and the blood vessel is restored and all that. Is there a risk for repeat limb ischemia? Thank you, sir.
All right, that's an excellent question. So statins have been known to have what we call a pleiotropic effect, okay? So the effects is not just regulating cholesterol regulation and all that, and reducing the LDL cholesterol and elevating HDL cholesterol. So definitely those patients, because remember, the pathogenesis of peripheral vascular disease is not complete if you do not have the cholesterol has to find its way into the intima layer, right? It has to be oxidized and become a foam cell. Now we have what's called little lipoprotein, little a. Even though, and I don't want to get to this, is like a bit complex, but even if your cholesterol is normal, okay, you can have a normal LDL, but you can have a small particle LDL or a large particle LDL. The only way you can know that is through NMR spectroscopy, which is not available here. So even if your LDL is normal, but your lipoprotein little a, that's the smaller particle, is high, those small particles they can find their way to the intima layer and cause plaque. So now, the fact that you have a normal LDL does not mean that you cannot take statins because your LDL little a, LPL little a might be large, might be higher than the larger particles, right? So you use it to modify the LPL-little-a, your cholesterol, and like I mentioned, the pleiotropic effects. There's a correlation with cytokines, interleukin-6, interleukin-12, TNF-alpha. We're not going to go into that, but to answer your question, yes, you have to put those patients on statins. And one of the Achilles of endovascular therapy is repeat revascularization. That's the thing that surgery has over endovascular technique, is repeat. Sometimes these patients will get repeat procedures because they get restenosis and things like that. And that's one of the advantages of surgery, to answer your question, okay?
Thank you, everybody. So we will take a short break now to stretch our legs and move around and network with one another for the next 15 minutes. And then we will be back shortly for the next presentation, which you do not want to miss. So we will have some people directing and guiding us for the tea break. Just give me a few minutes while they come in, and we'll do that shortly. Thank you.
from the smoke cannabis. Doctor say make a pop one of this. Make me fly like say I'm Aladdin. Come bring some kind melodies. Oh mama myself no do pass like this. So many things inside of my jeans. Slide down DBTs, DBTs.
Hello, everybody. Thank you so much for your patience. So in the next 7 minutes, we'll be starting the next presentation. So I'd like you to be a bit faster with the food moving from the table into the mouth. But in the next 7 minutes, we'll have our next speaker on the stage. We hope to wrap up the program as soon as possible so that everyone can get along to the rest of the business of the day. Thank you very much. Hello, everybody. Hello. Hello. I hope our mouths are not too busy moving to just acknowledge my greeting. Thank you very much. You're all welcome back. So can we please settle down in preparation for our next esteemed speaker? Thank you very much. So it's my pleasure to introduce Dr. Tayo Ojo. By the way, I was in clinical year when he became a young consultant. I don't know if he remembers me, but you see, at that time, you know, you used to spot SRs that had your time in those days. You know, when you are doing clinical year, they'll give you this list of topics that you must finish. Yeah. So this guy, we had spotted him. Very gently spoken, never used to chase us away, always had that time. It was like moonlight, stories by moonlight. We always just gazette him when he's coming, so that when he comes, all of us will sit down around him, and then he'll start breaking down those topics. So he's part of my own success story. I'm sure he's a part of many of us here. Thank you very much. It's a pleasure to introduce you today, sir. So as I said, it's my pleasure to introduce Dr. Tayo Ojo, an internationally trained consultant, neurosurgeon with many fellowships too. Dr. Tayo Ojo attended College of Medicine, University of Lagos, where he graduated with an MBBS. Hello, are we together? Thank you. I'll start that again. Okay. Sorry. Put it up. Is it on? Okay. Thank you very much. So, Dr. Tayo Ojo attended College of Medicine, University of Lagos, where he graduated. Yes, please. All of us in the house. Where he graduated with an MBBS. He trained both locally and internationally and obtained an MRCS Ed, FMCS Nigeria, and FWACS in neurosurgery. Dr. Ojo did various fellowships and training in different parts of the world under notable and excellent neurosurgeons. He did fellowships in neuro-oncology at Royal Melbourne Hospital in Australia under Professor Andrew Kaye, neurovascular Professor David Mendillo, and complex spine at Newcastle General Hospital, NHS in the UK. He was also WFNS Adult Fellow, Microneurosurgery, Vascular and Skull Base at Tübingen, Germany under Professor Marcos Tatagiba. His area of interest includes complex spine surgery, microneurosurgery, neurovascular surgery, aneurysms and arteriovenous malformations, epilepsy surgery, and transsphenoidal surgery for pituitary tumors and skull-based tumor surgeries. He is the convener of Lagos Neurosurgery course, which runs yearly to train neurosurgeons and improve the outcomes of neurosurgery in the region. He is also a national faculty to AO Spine, West Africa. Dr. Ojo was the immediate past Secretary General of Nigerian Academy of Neurological Surgeons, NANS, and the current president of Nigerian Spine Society. So, join me in welcoming Dr. Ojo as he speaks on brain tumors, a session that promises to be both brainy and brilliant. You're welcome, sir.
Thank you very much. And this afternoon, how protocols did you observed? Particularly Dr. Hueniro and Dr. Kuyero and Dr. Kogo and everyone here. So I'll talk about brain tumors. if we had this discussion 10 years ago, we will not have many people being interested as are today. In different fora then, they would say that brain tumor is rare in Africa, we don't see them. Perhaps many of us, when we were in medical school, we didn't see much. But I think things are changing. So for many reasons, one, we have means to diagnose them now. And two, we are beginning to get success stories. So people are now encouraged to pick brain tumor clinically and radiologically, and also to send the patient for early surgeries. And if we look at the epidemiology, we begin to see that brain tumor is about 1% of the population. And in Nigeria, if we take the population to be 200 million, so we're thinking that there should be at least 2 million people with brain tumor hiding somewhere. Of course, we don't see that much, or probably we don't get to do that much. So I will go through this outline, and my focus will be for us to be able to, one, make the diagnosis, and secondly, to plan how to treat the patients or send the patient for early surgery. Many times when we tell people about brain tumor, well, people think the world will stop. And they feel that there's no way forward, and as a result of that, it's all gloomy, but things have changed in the recent past. I'll talk a little bit about the anatomy, and the reason we have to talk about the anatomy is because we really need to understand how to pick a patient with brain tumor. I could walk in the market and see somebody with brain tumor. I may be able to pick some, either because somebody is acromegalic, or somebody has the cushingoid fissure, or somebody just having seizure, then I would know that something is going on. Well, we all know, well, for most of us here that are doctors, we can see the calvarium where the brain should sit. We have the tentorium, which will divide the brain into two compartments, the supratentorial and the infratentorial. And this is particularly important because they will present differently. We also have the falls, which will divide the brain into two, the right half and the left half. And the importance of this is because years ago, when we didn't have CT scan or the MRI, we will get the neurologist, well, I wasn't there, but that's the story. We'll get the neurologist to sit down with the patient and clack the patient and tell the neurosurgeon precisely where the tumor was. And most times they were right, so thanks to the neurologist. And also, we will talk about, we'll just look at it, what it looks like. This is what the brain looks like. And this is the frontal lobe, the parietal lobe, and the posterior fossa. You can see the posterior fossa is quite small. Small things could be very dangerous, and it also tells that the smaller they have, the less compliant they will be. So if there is a tumor here, it can take 5 to 10 years for the diagnosis to be made. But a tumor here will present very early. Maybe I shouldn't talk too much about the anatomy, but of course we know where the pons will be and the medulla oblongata, but this is important. This is the ventricular system, and there could be tumor in the ventricular system. And the way we look at the ventricular system is like the plumbing work in the house. So if the drain is blocked, then there will be accumulation of water, then the bathroom may be very dirty. If the pathway is clogged, then there will be hydrocephalus. And of course, the blood vessels there are very important. So, as a rule of thumb, when we look at adults, 70% of the tumors in the adult will be in the supratentorial region, whereas the 70% of tumor in children will be in the infratentorial region. And this is very important. So when I'm looking at somebody with brain tumor as an adult, and I'm clacking, then I'm putting interest in where it matters. When we talk about brain tumor generally, any cell can go rogue. And the different cells we have in the brain are the ependymal cells, which can give rise to ependymoma, the oligodendrocytes, the glial cells, and the astrocyte giving rise to astrocytoma. And when we stretch it a little bit and start looking at the cranial nerves, very importantly is the vestibular schwannoma, which is a different kettle of fish entirely. Presentation will differ. A child that can't talk, that can't tell about headache, that can't complain will present differently from an adult that could say, look, I was seeing very well yesterday, but at 2 a.m. today, the vision is compromised. So basically, children will present late for the same reason, and most of them, especially within the first 2 years of life, may present with hydrocephalus. The head will just start getting big. So if anybody sees a baby, in quotes, with large head, will need to look at what is causing that. But most of them will present with developmental milestones. He was walking before, he can't walk anymore. He was doing very well before in school, now he can't remember his times table. And with headache and seizure. In adults will talk and will tell, then you can clack. But if an adult has seizure as an adult for the very first time, it's a brain tumor until proven otherwise. I remember I gave a talk about that, and there was a lady somewhere in the country who had that, and she's been having seizures for 4 years, and for different reasons, she didn't get investigated, and she had that, and she did a MRI by herself, just hearing that, and she had a meningioma, and after the surgery, her seizure had gone. And that is why it is important to talk like this, so people know what to look out for and be able to send the patients appropriately. Sex. So male will present differently from females, especially when it has to do with tumors that are hormone dependent, pituitary tumors, craniopharyngioma, tumors within the cellar and the suprasellar region, and then reduced libido, erectile dysfunction, gynecomastia in men, or female with infertility, amenorrhea, and galactorrhea. Many people, especially ladies, don't know when they have galactorrhea until the doctor examines. You just realize the period is not coming, and the doctor will examine and see that there is milk coming from the breast, whereas the lady is not breastfeeding. So it's another important feature in brain tumor. Of all these, the site of the tumor really matters apart from the size. So tumor in the frontal lobe will present with personality changes. I had a patient years ago that had been in the psychiatric ward because he was behaving funny, and that had been on for years, and the wife had to run away because he started beating her. And towards the end, we did a scan just because he had a seizure, and it was because he had a very large tumor in the frontal lobe, which completely changed his person, and that was the reason everything that happened to him happened. So personality changes, disinhibition. So if somebody had been very well behaved and suddenly is beginning to do otherwise, it may be that something is wrong in the brain. In the parietal lobe, because in the parietal lobe here, we have the motor cortex, most likely the patient will present with seizure. And in this sensory cortex there, they present, oh, something is walking all over my body, and most people will attribute that to some other forces beyond medicine. So if anything is going on, we need to look further and be sure that there may be something going on. In the temporal lobe, which is somewhere here, they will most likely present with seizures or memory impairment. And we see this in undergraduates or people in school who are not able to do as well as they were doing before. In the cerebellum, now, posterior fossa, like I said, is not very tolerant. If anything is happening there, patient will know almost immediately. They begin to walk funny. And I've seen people, and when I discuss, well, I noticed it a while ago. I just thought it was a Gen Z kind of thing. So somebody who has been working very well and is now forming, we may need to investigate. But much more importantly is poor coordination and difficulty in seeing. So when we talk about tumors in the occipital lobe, many people will miss it, except you're a neurologist, because the part of the vision that is lost is not what we naturally would test for. It's just a quarter of the field, and many people don't even know until almost 3/4 is gone. And this is a patient with occipital lobe tumor presenting with quadrantanopia and difficulty in walking. For patients with brainstem lesion, of course, we'll know from ataxia. Supracellular region, visual deficit, tumor pressing on the optic nerves, and also by extension going into the cavernous sinus, and we can see any of these when we examine further. If I miss all these presentation by sight, the next important part is by size. If a tumor is small enough, it can be there for 5 years without anybody knowing. But once it starts getting to 5 centimeters, 6 centimeters, even in the least eloquent region of the brain, the pressure effect becomes a problem. And that is why there will be headache. And this type of headache is very classical. Headache that wakes the patient up from sleep, but it gets better by the day. And that is because when we sleep, we get less oxygen, and we have carbon dioxide build up, the vessels will dilate, the pressure effects become small, and the headache becomes significant. Very few tissues in the brain are pain sensitive. One of them is the blood vessel, the next is dura. Brain itself is not pain sensitive, meaning you can actually operate on somebody while you are talking to him without him feeling it. So headache, raised intracranial pressure, hydrocephalus. So the end point of any tumor in the brain will be raised intracranial pressure. As the tumor is taking space, the pressure starts building, then there will be headache, nausea, and vomiting, and lateralizing signs like hemiparesis and lethargic. And if nothing is done, brain on the left will start moving to the right. From the supratentorial, will start going infratentorial, and that will be shortly before the patient will decompensate. Neurologic deficits, seizure, is so important that if anybody has seizure at any time, it should be thoroughly investigated. Frontal lobe syndromes, visual deficit, and so on and so forth have been talked about. How do we make diagnosis? You really don't have to be a neurologist now to make a diagnosis. You just have to be a good doctor. And clinical history alone, you'll be able to tell who has brain tumor and who does not. And by the time you had neurological examination to the clinical findings, you can pick 70 to 80% of patients with brain tumor. So we've talked about the history, we've talked about seizure, and we've talked about neurological deficits. You will always know because somebody will tell you he was walking before, he can no longer walk. He could see before, he couldn't see anymore. It could be as salient as I could smell, but now I can't tell which perfume I'm using. Examination, and this is where everybody has to pay attention. We really have to examine to either rule out or confirm what the patient has. But very importantly is the mental state examination. I know many people will do general, you say febrile, he's anecteric. Neurological examination, GCS, by the time you're talking, you know his GCS is 15. But when it comes to mental functions, how much can the patient remember? Immediate recall, long-term recall, and this is very important. I see a couple walking, the man has brain tumor, it's the wife that is telling me the history. Then I say, okay, can I hear from the patient? Say, no, don't worry, I'll talk for him. Because he can't remember anything anymore. But I want us to pay particular attention to the eyes. The eye is the window to the brain. If anything is happening in the brain at all, the eye would tell. And that is why we must check the pupils, do the visual field, just do it grossly. Can you see my hand? Or you can't see. Many people with pituitary tumor would not know until their car gets bashed from the side because they have a tunnel vision. They can only see one way. and they will either hit somebody or people will start hitting them. And that is how we picked the pituitary tumor for many patients. Investigation for, generally, we need to do the blood work. If I'm thinking somebody has pituitary tumor, then I will do the hormone profile. And with this, from the history, you will know gynecomastia, galacturia, poor vision, amenorrhea, then you have to do all the hormone work. X-ray not particularly useful, CT scan and the MRI. So this is a child, well, she was actually about 18 thereabout, and you can see the brain tumor there in the posterior fossa. She's been quite doing poorly, couldn't walk, couldn't talk, couldn't see very well, and there is a tumor. So we must be able to look, I mean, from being doctors, we know what the normals are, and when we see the abnormal tumors or abnormal structures, then we can pick it. And this is another one with meningioma. This before surgery and after surgery. So I mentioned earlier on that in this environment, people present very late. And the reason is either they can't afford the investigation, they wish it away, they don't see the correct people to direct them to the right places. And here is a patient with meningioma. And if I put it in perspective, it takes about 5 years for a meningioma to be 1 centimeter. And by the time we're looking at meningioma that is 5 centimeters, then you can know that this patient had carried the tumor for a long time. Technology had made it so easy now that I can look at the MRI and tell which of the tumors are malignant or which of them are benign just by looking at the metabolite rates in the MRI, which we call the MRI spectroscopy. And if you go a little bit further, because the frontier had moved beyond what it used to be, just do a CT scan and go, just do an MRI and go. The correct one now is to do the tractography, and the advantage of this, it helps to plan which structures to avoid. So if a patient had a tumor here, and I know this is the corticospinal fibers, and if I cut it, it will be hemiplegic or hemiparetic, then I can plan my route through a safe zone and take the tumor out safely without compromising the patient. Meningioma is very common, and it grows so slowly, but it could be very devastating when picked very late, and when it's very close to other structures, and it's an extraaxial tumor that is not malignant, it's actually benign, but if it is very close to some other structures of the brain, then we have to wonder. So the commonest brain tumor is metastatic brain tumor. The commonest primary brain tumor is the glioblastoma multiformis. So when we put all the patients with brain tumors together, we have to pay particular attention to metastasis because breast CA, lung CA, ovarian cancer can easily get into the brain. So anybody with any of such has to be particularly screened for brain tumor. So this is a lady, breast CA, already operated. In fact, she already got the all clear from the oncologist. And a few years later, we could see the tumor. But in such cases, it can be more than one, and there are different protocols for that. If it's just one tumor and it's big enough and it's causing trouble, the treatment is to remove it. If there are many tumors there, then it's a different kettle of fish entirely. So I'll go to some specific ones that are common and that are peculiar. In children, very common brain tumor in children is a pilocytic astrocytoma. Unfortunately, it is a benign tumor if it is appropriately handled. And it's usually in the posterior fossa. The diagnosis is clear, but the presentation is the same. Headache, deterioration in level of consciousness, and declining milestones. Ependymoma is another one, but this one is malignant. The important factor here is that even after the surgery, the patient has to go and see the oncologist. And at diagnosis, the histological diagnosis will tell about the perivascular rosette. This is the blood vessel, and these are the ependymal cells. Technology has gone beyond just getting the histology now. Right now, what we do is to do the immunohistochemistry and do the genetic typing. And we find out that we can pick more and plan more for the treatment, and also being able to talk about the prognosis. This is one of the commonest malignant tumor in children. It will present the same way, and it is medulloblastoma. So anybody with medulloblastoma, ependymoma, they have to be investigated properly and managed appropriately. Choroid plexus papilloma, which is usually seen in the ventricle. So the commonest primary brain tumor, not the commonest tumor, the commonest primary brain tumor is a glioblastoma. And there is no cure for that. I know that usually when we talk to patients about brain tumor, what they want to know is, what did I do to have brain tumor? What can I eat to prevent brain tumor? The honest truth is, it is not what anybody is doing or not doing that is causing the tumor, just like some tumor. They just come by themselves. And the best that can happen is to pick it early and to see how one can get a cure. So high-grade tumor, very common, and they progress so rapidly that within months, the patient will be gone if nothing is done. And it will be something like this on CT scan. You just see an area that looks a bit wide. And then you look at the MRI, you can see perilesional edema. And if I put this together, this is actually the tumor, and this is the perilesional edema. So with all this, it makes the tumor to be relatively bigger than it should be. And by the time we see this and give some of them steroid, we should, the perilesional area would go. It would make the tumor smaller, and many of them don't come back until something else happens, because they will regain their function fully and think all is well. So this is breaking it down to the basics, the WHO classification. But the classification, if I was talking to neurosurgeons, would be slightly different from this. So it's classified as WHO grade 1 to grade 4. Grade 1, they are the benign tumor, like the pilocytic astrocytoma, like the meningioma. Grade 4 is GBM. And when we see this, we have to start talking about end-of-life care. So metastatic tumor, breast, lung, ovary, and so, they're quite rare in children. Not that we don't see them, but we see them rarely. And of course, sometimes we see local extension of malignant tumor, like Ewing sarcoma and neuroblastoma. Now, talking about the care for brain tumor. The pre-op management is quite important, and many people can help with that. If the diagnosis is made, you really want to reduce the effect of the tumor on the brain, and that is where steroid comes into play. And when we give steroid, we have to state it clearly. You can't take it forever. You can't take it for more than 2 weeks, even though the patient is feeling very well. Anticonvulsants if the patient is having seizures, and counseling. So this is the point that we lose many, because they've been around long enough to know that anybody with brain tumor, they don't do well, we can be cured, nobody can help. And the more they delay, the worse the prognosis. But I'm happy to say that in the past few years, there has been a paradigm shift. The success rate is higher now. There are many centers the diagnosis can be made, and there are many surgeons that can take it out. It has gone beyond 50-50, this one will not, to the point that you can actually say that, well, you'll probably do well in a few weeks. But the cure or the management is usually not a one-man show. It's usually a teamwork with the chemotherapy, with the oncologist, the occupational therapists, and sometimes too with the palliative care team. So let's talk briefly about the management. For surgery, If the tumor is benign, the aim is to completely resect the tumor because that can give cure, like meningioma, like pilocytic astrocytoma, like pituitary macroadenoma. But when we're talking about malignant cells, we can't take everything out. You know, if the tumor was in the hand, you can cut the hand off, but for the brain, you have to be a bit more circumspect. So we'll talk about maximum safe resection. And the basics for tumor surgery now is to do microneurosurgery because of illumination, because of magnification. And this is very important when you look at the structures in the brain. You look with the naked eye, everything looks the same. And you magnify it 10 times, and then you can say, this is a nerve, this is a blood vessel, or this is a perforator, and you know what to take and what not to take. And this alone, the microscope alone, gave Professor Yasha Gill to be the man not of the year, of the century, because it completely revolutionized neurosurgery practice, and that has made neurosurgery safe, and that is why many people are happy about it today. CUSA, neuro navigation, which tells where we're going. It's like using GPS or Google Drive, and we have it in some centers now. You can safely say this is where the tumor is without you opening the brain. So surgery, gross total excision, subtotal in cases that it is not possible, and in some cases you just have to take a biopsy before you can move on. Pilocytic astrocytoma before surgery, 1 year after surgery, completely gone. Pituitary surgery, this is a very important part of neurosurgery in the recent past. 20 years ago, if anybody, would the video play? 20 years ago, if anybody had pituitary surgery, usually it would be a disaster because we have to open the head, go through the brain, look for where the pituitary is, where the pituitary gland is, and by that we'll disturb a few cells in the brain, and the patient wakes up struggling with so many things. But right now, we go through the nose endoscopically, take the tumor out, 3 days, patient is back home, no scar, everybody is happy. So if I put this together, we will go through somewhere here, lift the brain up, and remove this. But now, this is through the microscope. This is the cellular toxica. We're enucleating this tumor, and we suck it out, and in 1 hour, we're done. No scar, injury to the brain is minimum. And sometimes we really have to open the brain because the tumor is at the skull base. And this is another example of what technology has done to the tumor, the management of brain tumor in the recent past. We can magnify it. What you see there is the optic nerve, and what we see there is the olfactory nerve. And this particular one is the internal carotid artery. And you can see, so you're playing around maximum diameter of maybe 5 millimeter or less, but with microscope it becomes like 10 centimeter, and you can maneuver stuffs. So meningioma, like I said, is very common. The aim is to completely resect it, and in doing that, like I mentioned earlier on, it is best done under magnification and under illumination. I think this is not playing, but I won't wait for that. Okay, I'll move on there. So GBM is a disaster any time that this diagnosis is made because the time or the clock starts ticking. You can't remove it all. If you left a cell, it will grow back in weeks. And the treatment is to remove as much as we can and then send to the oncologist to give radiation and perhaps chemotherapy. And this is why we have to talk about the adjuvant treatments for cases that we can remove completely. Sometimes some tumors are benign, but they are in very delicate part of the brain that we shouldn't go. And for such, we either take a biopsy or just send for radiotherapy straight away. So this is an example of an inoperable tumor. I got this 2 days ago. I wish I could pause it, but you've got this big tumor, which I am sure is meningioma, but the tumor is encasing the internal carotid artery. So if I had to take out the tumor, the internal carotid artery will follow, and so many other things will go with it. It's the example of the TARS and the width. I mean, you just wait until you can sort it out later. And because of that, we can't talk about surgery here. We have to talk about chemotherapy and then other treatment. Pontine glioma, mostly seen in children. So this is another example of where we can't even take a biopsy. We just have to make the diagnosis. So this is probably a child, difficulty in walking because it's got this diffuse glioma in the pons. And if I just put it technically like this, all the functions of the brain cannot send signals down to the lower part of the body. And not a very good sight to see, because one, we can cure it, we can remove it, chemotherapy, radiotherapy, all we end almost in the same part. We can't talk about brain tumor and not talk about complications. For different reasons, we have to talk about complications, so it does happen. And it is better in high volume centers, high volume surgeons to reduce the possible complications. And like I said, it's a teamwork so that people know what to do, what to look out for. If the bone flap is involved, it has to come out. And the complications include stroke, blindness, recurrence of the tumor, and unfortunately, sometimes death. But there are new frontiers now. Genetic profiling, molecular biology, immunohistochemistry is helping in making the diagnosis to be more precise and also tailor the treatment according to the genetic pattern. And if I put this into perspective, so many neurosurgeons will shiver a little when you mention craniopharyngioma. And it's because you can't remove it completely. Most times it's attached to the hypothalamic and the thalamic region. And by the time you try to excise it completely, there is a problem. And so therefore, we struggle, we keep going, keep on removing. But now, with genetic modeling, if it was positive, there are medications that can completely wipe it off, and that is a very good point. Immunotherapy, in some centers, they have gamma knife, where tumors that we shouldn't open the brain for, we can just send the patient for gamma knife, and that will be the end, especially for slow-growing tumors. We can also now talk about brain tumor without talking about end-of-life care. Because we have to come to reality, there are some we can't manage. And I saw somebody with GBM, and I struggled because I know who the person, what he has and how important he was. And I have to carefully say that, you see, it's GBM. And I'll cite examples of the Vice President's son, John McCain, and very important people who had it even in the best of centers, and tell that within 1 year, it will be over. And this is very important. I don't think we should shy away from this, about talking about end of life, because it can help somebody to put his house in order and get ready for the eventuality. And when we talk about children, especially when we are doing palliative care for them, it helps in bringing closure to the grief and to the experience. So there have been different articles, should I tell, should I not? And in the particular study, they found out that people that discussed the end of life, they had no regrets, but people that didn't discuss, when the patient eventually passed, they will, maybe I should have told, and so on and so forth. So we have to talk about it and prepare. So in rounding up, brain tumor, very devastating. We don't know what is causing it, but we know that if we pick it early, and we send the patient appropriately for definitive care, we can get cure, perhaps. we can prolong life, and we can improve prognosis. Microneurosurgery is the hinting now. If I'm doing brain tumor without magnification, without microscope, it's like saying, well, people are walking from Lagos to Kaduna years ago, but now I want to walk. Not very advisable when other people will fly. So without the microscope, without high CU, without teamwork, we are putting our patients in more danger than they already were. And teamwork makes it better. Thank you.
Thank you very much, sir. Thank you, Dr. Ojo, for that insightful and thought-provoking presentation. You've taken us deep into the world of brain tumors with clarity and clinical depth, reminding us of the importance of early diagnosis, precision, and multidisciplinary care. So we'd like to open the floor now. Time is well spent. I would like to wrap up the program shortly, but we'll open the floor for the next 15 minutes for questions and answers for Dr. Ojo following his presentation. Where's my colleague with the microphone? Thank you very much. So, yes, we have someone here. All right.
Thank you very much, Dr. Ojo, for that presentation. I'm Dr. K from Iwosalagon Ikoyi, and I would like to ask a question with regards to the maximum safe resection margins for the malignant tumors. Is there a fixed measurement in terms of base millimeters or so based on the gross picture of the tumor intra-op? Or basically, is that maximal resection margin determined with the aid of intra-op radio, like intra-op imaging, or we have like a fixed, let's say, resect 2 millimeters around or something like that? So that's what I wanted to ask.
Thank you very much. That is a very important question. And it's very important because while operating, I will have no clue how close I am to the normal tissue. So it's not defined. It's very, very subjective. In fact, when we talk, we just say, just remove as much as you can safely remove. So what I may remove may be less than what you may, depending on the gadgets that you have. At a time, I was doing a GBM with somebody in Germany, and when we thought we were done, we had looked at the tumor, we could tell that we were in the normal part of the brain. Then we took the patient to intraoperative MRI. So few centers have that. And when we scanned the patient, we were still gloved, we were still in the theater, we realized that we were, in quote, meters away from where normal was. So the answer to that is very subjective, but literally it's like telling you, please just do as much as you can do without making the patient get worse. So when I'm operating, depending on the structures around me, if I was doing the frontal lobe, I could be very generous with my margin. I can even afford to take part of normal. But if I do posterior fossa, I would rather err on the side of caution, take a biopsy, debulk as much as possible. When I see anything looking close to being normal, I'm off.
Good afternoon once again, Dr. Odeshku here. Thank you, sir, for the lovely presentation. I just want to find out what is the role of monitor, if any, in the management of brain tumors, because usually we sometimes have that dilemma when we have patients with brain tumors who have raised ICP. Do we give monitor? Do we not give monitor? I just want to know if there is a guideline for that. Thank you, sir.
Monitor works. It probably works all the time, but we can't use it for longer than necessary. So if a patient has brain tumor and the patient is already coding, intracranial pressure high, GCS is dropping, you must give monitor immediately. It will work within minutes. And I've tried that many times. By the time the patient is waking up the following morning, as if nothing happened. Dexamethasone works, but not immediately. It takes time. So if a patient has raised intracranial pressure, you have to give monitor at the time you are sending it to the neurosurgeon to buy time, and it can be a lifesaver.
Right, sir. Good afternoon, sir. I'm Dr. Ajayi from Osolagun, Igali. You've mentioned a lot about brain tumors and recent interventions. I think it's quite important for us to also look at the other players beyond we, the providers, and also the carers, the patients, also the financial implication of all of these having to seek care, neurosurgical interventions, the new interventions like the immunotherapies and the likes. I want to ask what's your take on how we can develop maybe more affordable means, even as we're organizing this as Osolagun and amidst other healthcare providers, financial costings and how we can make this more affordable?
That's a very deep question. In many places where things work, patients don't pay out of pocket. Because if, even in the best of centers, by the time you are doing brain surgery for 70,000 pounds, I mean, you feel it. So what we can do would be to encourage government to improve on the health insurance. All these stuff that I mentioned are not cheap. If a patient has to do immunohistochemistry, it's a lot of money. And if a patient has to do genetic typing for craniopharyngioma for a patient that I recently operated in the public sector, 2.5 million. So you can see that the cost is enormous, and not many people can wake up and put hand in pocket and bring out 10 million. So it's not going to fly as long as the current coverage of health insurance is sustained in the country. We need to do a lot better than that. And the answer would not be for me or for you. It has to be from policy. It has to be from improving care. But the basic, which I must say here, is that most centers would have the basics: microscope, ICU, and the like. And I wouldn't expect anybody to do brain surgery without any of such. And it's not only in private sectors that we have that.
Okay, a warm round of applause for Dr. Ojo as he steps down. Thank you so much for your questions. Please sure to engage Dr. Ojo during the lunch period. And now we have come to the nearby end of our program. I'd like to invite our MD, our CEO, to come up and just share a few words. But as he does that, I will just speak a little. Yes, his eye is shining. Yes, you can come up, and then I'll just read it so that they can be admiring you as I read all of that. Yes. So Dr. Olubisi Oyeniran is the CEO of the Osolagun Hospitals. He's leading its centers of excellence in delivering high-quality, patient-focused care in Lagos. Under his leadership, the hospital has achieved JCI reaccreditation, reinforcing its commitment to global standards. His previous roles at the former Gold Cross Hospital and Lagoon Hospitals include hospital administrator, medical director, and managing director, building deep expertise in clinical operations and healthcare leadership. He is certified by the Medical and Dental Council of Nigeria and the U.S. Educational Commission for Foreign Medical Graduates, ECFMG. He also holds an MBA from Lagos Business School and has completed several executive leadership programs. Please a warm welcome to our MD CEO, Osolagun Hospital.
Thank you, Dr. Agada. Good afternoon, everybody. Good afternoon. Thank you so much for your patience. I really hope it was we felt it as an inspiring and enriching session. I would really like to thank everybody that has attended, both internally and externally. people from the Lagoon family, our doctors, primary care physicians, our specialists as well. Then our stakeholders from the insurance company, our corporate clients, thank you for making this afternoon a very satisfying experience for us. I bring greetings from the board of directors of Iwos Lagoon Hospitals. One of the core foundations of our organization, one of the things that set us apart is training and human capacity development. And it's from that perspective that we figured out we need to do so much of this very highly technical and highly needed sets of gathering in the academic space. So please be on the lookout. We are going to have a cadence for this, which we will communicate. More and more of this training will be happening within our space. I cannot close this meeting without acknowledging the presence of Professor Badero and Dr. Tayojo. Prof and Dr. Joe, in my own assessment, happen to be two of the most brilliant minds, not only in this country of our generation, I must say. And I know many, many brilliant and many, many intelligent people. And it's from that space I can comfortably say they are. But maybe much more importantly, they are two of the most unassuming people I know, right? Dr. Badero, you can walk past him without even knowing who he is or what he has the capacity to do. Similarly, Dr. Ojo. So we really do appreciate the good work you are doing, not only within the Lagoon system, but even within the healthcare space across the world. So we are very grateful, we are very proud to be associated with you. I must say, in the midst of all the knowledge that was shared today, I particularly appreciate the fact that there was an emotional appeal to everybody. And I don't know how this resonated with a lot of us, that even as you get to know these, get the socks of the patient, touch the patient, send them for ABI, do a cardiovascular assessment for them, refer them early, you know. So those are the kind of things that stick with us and then enhances our practice. And in line with that, I remember I had a chat with Dr. Badero not too long ago about coffee intake. And it's quite telling that anytime Dr. Badero is around, my coffee intake does drop to almost zero. Let's not talk about what I do when you're not here, Dr. Badero. And then for Dr. Ojo, many, many times, they've carried patients from one hospital to another hospital to another hospital. And then when they get to us, many times I send them a summary. Most of the time, the answer is usually, yes, you can do this. Yes, you can do this. Yes, you can intervene. So that level of confidence comes from a place of competence. So we appreciate the investments you've done in yourself, and then we are all glad that we can benefit from what you have done and what you continue to do. So if you really need to reach out to Dr. Badero or Dr. Tayojo, please let us know at the end of the meeting. And I also am conscious of the questions around bills and tariffs, so we are able to have those discussions also in much more details. But lastly, and not the least, I want to appreciate the organizing committee, led by our primary host, Dr. Kuyoro, Dr. Agaja, the moderator of the program, the Iwos Lagoon Hospitals M&G team, for putting up a very successful afternoon. So thank you. I'll see you all at the next one. So thank you very much, everyone.
Thank you very much, sir. So lunch is served, but so is networking. Feel free to meet with the speakers and exchange ideas, ask the remaining questions that you have, and let's hope for future collaboration. Thank you for making this Doctors Forum a success. We wish you Godspeed. Okay. So please, yes, just wait around. We will direct you for lunch shortly. Thank you. Okay, so my director has asked me to please let you all know that there's a setup at the back to keep us engaged and promote the networking. We're having some mocktails available to help us mingle and tingle for the rest of the afternoon. So please do not be in a rush to leave. Thank you very much.